I know it can be a long day of sitting, so I'm going to do the teacher pause right now. I think some of my, okay. So I know that, feel free at any time, we will be kind of building in a break later, but feel free to get up and take a restroom break or grab some extra coffee or anything like that as well. So we're going to move into our panel discussion now at this time. We're going to, and how we're going to do this is, I'm going to just pass the microphone down. We do have Jamie Steig, who's going to be joining us here a little later. He's teaching right now, so he's going to be joining us later. But we're going to pass the microphone down, and if each of you can just give, we'll kind of try to keep track of time here, but a little overview, 5 minutes or less, of your particular innovation or expert topic area that you're doing in your pharmacies right now. And then, so give it just a quick overview and then pass the microphone down. Okay? So we're going to start with Jessica.
Hi, I'm Jessica Bigler. I work at Point Pharmacy in Fargo. I think I'm supposed to be talking about workflow, but just trying to integrate platform into our daily workflow that we did to try to capitalize on those opportunities rather than spending just great like extra time. And we started very slow. It was a very slow process, but just doing half the things that wanted us to do. So just trying to make sure that we started out by just printing out the tip for the CMRs that were in the platform and attaching them to things that were ready to pick up. Or just putting little notes in patients' profiles so that when they did call or when they did come up to pick up the prescriptions that we were just trying to do it right then and there on the spot rather than scheduling an appointment, capitalizing on the opportunity to see that they're either already doing what the tip told us to do or doing a complete medication review. Or it says you have an online prescription, so we're doing that in addition to that.
And that's Outcomes MTM, correct? Yep. Okay, Stan.
Good afternoon. My name is Dan Federley. I am here representing White Pharmacy. And what I will be here talking about today is the first together within our pharmacies. Our journey on implementing CMM started in 2018, so going on about 6 years in this process. It has been very fluid and moving and backwards and reading certain of the practice and develop is in order to begin and I hate that. And really we had started the journey on just MTM services prior to this, but as some of you may know, for QA the season of this service in our Minnesota. And really that started to in partnership with the plans that we work with. Because in Minnesota, many of the services that I work with do have CMM as their standard of care for MTM service delivery. And so that required a lot of change in our organization to support the comprehensiveness of a CMM-based service for our patients. And just to highlight some of those milestones and things that we need to put into place to support the implementation. If we would adopt that, as we just saw one option for a documentation platform earlier today, really making sure that we have all the capabilities to document peer service, being able to billing or roster billing, ensuring that we could be compliant with CMS requirements. So take away or any data elements required for reporting purposes. And then also just important to recognize that we are in a community pharmacy. And so ensuring that we had efficient workflows to be able to support our pharmacists to deliver the service within their workflow pharmacy. We also needed to establish contracting and credentialing in order to support the service. We had existing contracting that needed to be and certainly the journey of contracting both at the pharmacy level and at the organization level. Pharmacist actually, that is definitely a developing topic and then and that's something had to invest the time in as an organization to support our pharmacists and credentials so we can build services. We also had to make adjustments to our financial system. This service, so being able to collect payment and submit for reimbursement of the service required more changes in how we did those to support the service delivery. In terms of implementing, we had training for our pharmacists and our whole pharmacy teams. We had different engagement tools for our patients and providers. We initiated a quality to provide assistance to the service. The service was accomplishing our intent. So those are just some of the 60 elements that we need to accomplish in order to.
I'm talking to both monitoring today. And I wanted to relay actual pharmacy kind of from beginning to end, just with billing, patient training is something we had an idea of what we kind of look at. We had a 72-year-old female patient come into the pharmacy. She is a type 2 diabetic, which is really nice that these CGMs are expanding into type 2 diabetes. Originally, they were mostly like type 1 diabetics, and we've really been seeing the benefits of that, just with outcomes and patient feedback and satisfaction. In June of this year, her A1C was 13.4%. Their current medications were metformin, 1,000 milligrams twice a day, and Lantus 25 units twice a day as well. She came to the pharmacy in about July, expressing some interest in Dexcom because a friend recommended it to her. From there, we sent out requests to the doctor's office. Luckily, she goes to a doctor we have a pretty close relationship to, but it's still probably important. Even if you don't work with that office regularly, you can still reach out to them, leave a note with them, let them know the patient is interested. And then we also had the patient fill out CMS paperwork so that we could bill it as a durable medical equipment. And this patient has Medicare over 60. With billing and the scripts of those, it needs to have patient information, directions, doctor's signature, and most importantly, a diagnosis photo. That's often what's missing on billing. And sometimes something you have to go back to the doctor and ask your ICD-10 for that. Once we got all that covered, if we had to order it, we got to order it in. This patient's plan preferred freestyle Libre, which is kind of the main determinant on which one you're going to use. We often use Dexcom or freestyle and insurance, which one that you can do or which one the patient can most cost effectively afford. And then we kind of set up a fairly informal appointment time for the patient for her to come in and do first step. So she came in July. We went over patient training, sensor placement, kind of tips and tricks with that. If the sensor were to fall out early, which we could contact to get a new, and then also we would bill her a new one if it was her second month. Libre is changed every 14 days. Dexcom's every 10. You want to know the main difference between Dexcom 6 and 7? 7 transmitters are already built into the sensors, whereas Dexcom 6, the transmitter is in place every month and it's taken out and put into each new sensor for 10 days. Also, Libre does not do continuous data into the receiver for the transmitter. Libre, you do need to put the receiver somewhere else. And they recommend you do that about every 8 hours, otherwise the patient doesn't lose data. Luckily, we've had no complaints on patients on Libre doing this, and they're usually pretty active about before they eat, when they wake up, where they need some, like to see their trend down on their peak. But just to know the difference between Dexcom and Brave. And that patient training and that sensor placement is also billable to Medicare. And it should also be billable to other entities as well. The only thing is with Medicare, when you run it through, you get that green caption, that doesn't mean you're fully paid yet. Comes a couple weeks later. With the training part, we like to put that in if the patient gets a receiver as like an admin fee, like what you would do with vaccines. And then hopefully you get that reimbursement there. And then patient came back in August to get her refills and also her Lantus was switched to Novolox 70/30. Then we did a follow-up patient. Patient got feedback on her upon pickup with her refills. She had nothing but good things to say. Painless. She liked that we went over it together. She placed that first sensor on herself, so she was confident to do it at home. She really likes seeing, like, when she peaks after she eats, seeing her medications work in real time, but just be real personal feedback. Felt like she was more in control because they don't feel different when they change or start medications. And I think that really helps with adherence. One of her big things was getting the alarm set for low blood sugar, glycemic events. And within that first month, she had never up she had woken up, was sweaty. So very checked her blood sugar was under 80. That's what she had wanted it set to. Heavily factory settings, covers that anything under 70, the alarm. So that is something you might want to manually change patient. And she was able to know how she felt and was able to avoid other episodes under 80 in the future because of how she felt. She mentioned just when I saw her yesterday that she had started to feel a little sweaty and didn't know why. I checked her blood sugar was at she one of her peppermint candy. And also recently in September, she had another A1C checkup and it had dropped down to 9.2%. So just in 3 months, she went to 13.4. Yeah, that's information. We were really excited for it. She was really happy with that. But just seeing in real time the benefits of continuous glucose monitoring, because usually A1Cs, especially if they're over 10, patients feel like they can't really get a hold of that on their own, and being able to see that data in real time and accountability, able to see which foods really need her peak and which ones don't, and which ones can keep her at a good plateau. They also say time in range if that is above 70%, either 70 or 80 equates to about an A1C and a full around 7. And if they're time in range, which means they're between 70 to 180, that's over 50%, that's about a 9 on the A1C scale. So those are just kind of correlations, they're not exact, but it's good to see the patient is knowing it and she's seeing a real outcome benefit from that. I also have some reimbursement numbers if you guys are curious about that. This patient specific piece. So it is always important that we get reimbursed for the work so we can keep doing this for patients.
Hi, I'm Steve Peterson from St. Alexis Outpatient Pharmacy, and I'm talking today on expanding immunization services. About a year ago, I implemented the VFC and VFA program in the community setting, in the pharmacy setting. So the VFC is the vaccines for children. That's for the uninsured, underinsured, which is if they have private insurance, but it doesn't cover vaccines. And then American Indians and then Medicaid enrolled are eligible. And then the 317, or that goes up to the 19th birthday, And then the 317 program is for or underinsured adults, and that is for tetanus, meningococcal, MMR, pneumonia, for 19 to 64 with high risk conditions. And then HPV, influenza, you need to pre-order that. Although that first year we couldn't do it, but this year we're ready. And then adult classified as A and B. The enrollment process is fairly simple. You just have to do a vaccine management template, which gets updated every year. And then an annual education, which is a lunch and learn that they provide. It's really easy. You just do a post-test afterwards. Medical director signature, which in our case is pharmacy, PIP, BFC and BFA survey. And then you need certified probes and data loggers. And we use the VersaTrack system already, so it's easy for us to implement all of that. And then you need to maintain appropriate vaccine inventory. Your fridges need to qualify. There's a site visit, and then we had to edit our consent forms to make a couple small adjustments to include screening for insurance, and then if we use state or public supply. And then for billing for that, you can bill $20.99 admin fee per dose. You can't turn anyone away, so if they cannot pay, you still have to give the vaccine. And then it can't be sent to collections either. And then you just have to maintain your records for 3 years.
I am Hannah. I am a pharmacist at Gateway Pharmacy in Bismarck, Kansas. And I am here to represent the one program that we have been doing at our pharmacy. So that's screening for opioid prescriptions. So at Gateway, we try to screen every single opioid prescription. Implementing that through our workflow has been a work in progress on when at what point we should do research. And then chronic opioid prescriptions we try to do every 6 months. But the biggest thing is what is your doc station? You get first for the first time that you actually put it in a doc station, follow-up call a couple days later. Those follow-up calls are really helpful because you can reiterate that you can dispose of the pharmacy of medications at your pharmacy. And a lot of patients don't realize that they can get rid of them at wherever they go. So at whatever pharmacy. Otherwise, we have a couple different locations within the department. So we have some competition, see who can do the most screenings. And then every month, the one program sends out a lot of different statistics. Crazy and shocking that every week 2 components damage. So pharmacies role in say opioid attribution as well.
I am Nathan Schlecht. I have Foreman Drug down in the southeast corner of the state. And we also have a channel pharmacy in Winter that we operate. I want to start out with just a quick little story. It won't take long. I had the chance to go out to Washington for kind of non-pharmacy related business. But when I first graduated from NDSU about 32 years ago, I guess now, I started my career out north of Seattle, a little town called Cedar-Woolley, Washington, kind of a cool name for town. I was hired by a chain pharmacy out there. Chains were big back then. I kind of won all the West Coast. It was Pay and Save drugs. And they came right to campus, interviewed me, hired me on the spot. And I intended to go out there and work for them at graduation. Well, before I even graduated, that chain was bought out by another chain and turned into Payless, which was another big chain there. So I moved out there, started work at Payless Drugs, and I didn't stay out there too long from moving back, but since then, Payless Drugs has all been bought up by Rite Aid Corporation, so they turned into Rite Aid stores. And then not too long after that, I think Rite Aid had their problems in pharmacy, and kind of goes to show the pharmacy is not an easy business to be in at times. And financially, it's getting tougher and tougher, and some of these big corporations can't respond and make changes fast enough, I think, to adapt to the new situation. Well, when I went up to Seattle last week, I thought I'm going to go out to Cedar-Woolley. I'm going to see where I have stores, maybe take a visit and see how it's changed. And I had in my mind the idea of what it would look like, because I had a picture of where I worked. We went up to Cedar-Woolley and went to the building where my store was. Here it's a big, nice looking Goodwill store. So right in yourself too. So, it's just kind of, the reason I say that is we've been at Form and Drug now for 26 years in business. It takes a lot of work, but I think part of the reason is we've been able to adapt, try new things. We have a very small staff, but that makes us very nimble, I guess, at responding to changes and trying new things. We don't have a lot of bureaucracy, we can just make those decisions. And tobacco cessation is one of those decisions we decided to get into a couple years ago. We started in June of 2023 through the Center for, I guess, the CAP Center and the program for special projects. Tobacco cessation, it was very easy to get into, in my opinion, because they allowed us to go through some of the CE programs, some online training, some in-person training, and really gave us kind of the building blocks to set up the program, even just going as far as how to incorporate it into our workflow, what kind of process we should be looking at. They didn't dictate exactly how we should be documenting exactly how we should do it, but we were able to come up with that on our own. I think it's working pretty well. We are seeing patients just about every day. We have some contact with the program as far as trying to identify those patients that may benefit. We do a lot of asking patients about their tobacco usage, both at the cash register, when we're doing patient counseling for prescriptions that they're picking up. We've even incorporated it into our vaccination program. It's part of the questionnaire when we do vaccinations. And we've had a lot of discussions through that. And also through all of our MTM work and things like that, it's always a part of the conversation. So that's how we identify our patients. We've had very good success, I think, for a small store. And we are a small store in a very small town, about 500 people. So we don't have a huge population, but I feel like we're really making a difference. And we've been very successful at billing for our services, both the initial consultations, the follow-up, and through the I guess, sale of tobacco cessation products, things through the pharmacy benefits. We've been very successful, and I think it'll never be the main emphasis of our business, probably as a pharmacy in a small town, but it is one of those building blocks that we added to our services, and definitely is helping us diversify and add to our viability.
This one has another mechanism, so 1 second here, it's not the same as the other one. Maybe. You know what, I'm gonna use this one. Okay, maybe. This one. And open it and push power. Testing, no. And then unmute. Tap. Be slow. What am I doing here? Maybe I'll just pass this around. Testing. Oh, as soon as you got up there. Sorry about that. There it goes. Okay. So now what we're going to do is we got a little introduction from all of the different pharmacists and the services that we provide, and we have some questions that we kind of prepared for them. We'll also have opportunities for you in the audience to also ask questions in particular. So their first question is the primary motivation behind the decision to implement the innovation. And so I'm going to just kind of, I'm going to start asking with one of you, and then a couple, then if the rest of you can kind of chime in and just pass the microphone down a little bit. But Nathan, why don't you start? So, you know, did you see a need within your pharmacy community, or what was that motivation for you to start that service?
Yeah, our patients that very obviously are smokers and tobacco users. Although this is identified, we didn't even realize we're maybe vaping or using those nicotine pouches, that highly addictive nicotine pouches that we're using kind of distribute. So it's definitely in our area. We also are very close to the Winter Bobcat manufacturing plant. A lot of smokers, tobacco users up there. So we kind of knew that. And maybe later on we'll talk a little bit about how we try to reach out to that manufacturing community to get more outreach in our program. But, yeah, and the other motivation I kind of mentioned earlier is to try and diversify our services. I could see that in a small town like ours, maybe we're hovering around maybe 120 prescriptions a day average. It isn't probably going to pay for the 2 pharmacists that I have on staff and my overhead. So we had to look at other ways to try and add some revenues and maintain our business.
Sure. That's good. So we'll kind of pass it down. How about Kristen? You want to talk about, implementing the VFC program in St. Alexis and why it was you decided to, because you were one of the first pharmacies in the state. Now we have a few more that have added on, but you're the first pharmacy in the state to really jump into the VFC space.
Is this working?
Yep.
Yeah, I guess the reason I decided to implement it was because we would have patients coming to our pharmacy, especially kids, or to our immunization clinics that didn't have insurance or couldn't pay for it. And then when you turn them away and tell them you have to go back to your doctor's office to get this, 9 out of 10 times they don't come back. So you have to do it when they're willing to do it, when they're there. And usually I make the call to just take the loss, but at least now we're getting the product for free, even if we don't get the reimbursement for the pregnancy.
Sure. And then kind of going on with glucose monitoring too at Madison, now, and you said you guys you are billing for this. Is that correct? So you're actually billing for the services that you're providing?
So we are billing mostly for the send service receivers for the patients that are wanting those supposed to use their sensor receiver. So all these systems do have apps, and we can use their own phone as the receiver of the data. And then but some, especially this patient, she wanted a receiver, she wanted it separate. It's just like and the patient training part of it, we're just starting to bill it. So we haven't had too many new patients needing patient training with these systems. So we're first trying using it as like a fee or clinical service fee, similar to what we're doing when we bill vaccines. We add in that app for giving it. Just takes a couple weeks to know if that fee actually goes through or if there's something that we need to adjust. So right now, that's kind of how we're billing it. And I'm feeling confident that it'll work. But like I said, especially because this first patient was Medicare, and didn't get that reimbursement approved right away. We're still kind of in the waiting game on that. But it just seemed like an easy addition to, since we were already doing meters, test strips. It just seemed like a very common sense next step to also promote these. And then with it having billing codes for the training, that also is something we want to make sure we're getting reimbursed for. Because it just takes 15, 20 minutes to train a patient on using these systems if it's their first. Ensure that they're dexterous enough to place their sensors. Oh.
Have you tried the room for the monitoring?
So we've only just started, the Carrington store specifically, I work in Rockford with their sister stores with each other, has just started A1C testing and blood pressure. I don't know what they're billing for that, but it seems like we're headed in that direction to look at their time in range, to look at their peaks even after they take their medication, possibly to look at adjusting medications with a CPA. But I think that'll take probably more in-house training before our pharmacy are both actually doing that. Especially since it's not something we're totally used to. It's still kind of a new idea, but I can see it heading to where we can change and adjust that for patients.
Thank you. So Jessica, maybe you can talk a little bit at South Point again, motivation. What was it that kind of, so were you doing outcomes MTM before and decided that, there's something you need to do differently with your workflow? Like, what was your motivation to try this different approach?
So I can't speak to the numbers or anything, but Jeff or said that some of our These contracts were paying differently based on your outcomes review.
Hmm.
I don't know the details behind that, but so that kind of became more motivation. And there, it goes 1 to 5 on outcomes is your rating and you're sitting at 2. Today we are at 5. So that's been kind of a motivating factor of seeing that number go up. It was also just utilizing the tools that we already had in place and the platform that was already in place and how we can capitalize on those moments that, again, the things that we already do on a daily basis, but getting those small payments from outcomes.
Okay. So we'll move on to our next question. And this will be more for, for Sam and Hannah, maybe to talk about them. We'll go along down the lines too, to see if anyone has anything to add. But what was your, when you look at the implementation part of it, what were some of the modifications that you needed to make during the implementation process? So for, implementation of the one program in general and the pharmacies, we'll get to you, Hannah, and then right now for the CMM part of it for Sam. You alluded to this a little bit, that you had to do some things differently. What was it that you had to do?
Yeah, I think when we kind of look back at our journey for implementing CMM, we put a lot of emphasis and resources as the foundational structures, just eventually the contracting and the platform, and I'm really confident with that. And kind of looking back, once we got to the point of implementing our pharmacies and realizing our pharmacist teams are key to deliver the service. We can do it again, and starting with that to do it in parallel and the structure development. But regardless of kind of where we started in the journey, we had to kind of retrain and redesign our trainings for our services in our pharmacy. Fortunately, our pharmacy teams had experience doing traditional MTM services, such as a comprehensive medication review or targeted medication review through state programs. And so they had that foundational knowledge of delivering MTM services for patients. But for CMM, it's more comprehensive and holistic in what we're delivering for patients. And so some of the training and things that we needed to do differently was we needed to go back to the basics, and that included reviewing the pharmacist patient care process. It applied to the CMM process. Also looking at some of the standardizations that are out there that we fully implemented, such as the medication therapy problem framework that the Pharmacy Quality Alliance has put together to add some standardization on how you're documenting the care that you're finding. We also had a kind of more structured process within our documentation platform to help guide the pharmacists in their assessment. So really going back to the basics on assessment of medication therapy, focusing on indication, efficacy, safety, and adherence to help provide a guide to make sure that we really are being comprehensive in the service. Yes, we needed to kind of go back to the basic and just the philosophy of the practice and really be more wholesome in what CMM means for the patient and our intended outcomes that we're trying to achieve. And really focus on the shared language that our pharmacists are using, the language consistently. We're explaining the service to our patients consistently. And that really helped us be able to kind of expand this to additional pharmacy teams. At a faster rate. We also implemented training around motivational interviewing techniques, both external resources to help with that, and terms of things, just knowing that in order for pharmacists to be successful at accomplishing improved health outcomes, you really need the patient to be involved in that. And so, training our pharmacy staff, new techniques has helped us. And then just utilizing resources on patient, particularly the chronic diseases that we find. So I was really happy to see the guide that was on the table today for because those simple, easy resources are very, provided for.
And then Hannah, do you want to talk a little bit too about that, about just the implementation and implementing
the program itself into the one program into your pharmacies?
Yeah, so implementing the one program, it's in two big pieces. The first one was educating staff on why it's important to ask patients about doing the screening. And everyone was kind of hesitant on the verbiage. And so we just kind of blanket statement that the screening, we have everyone with an opioid fill out pharmacists and counseling. Important. We ask every single person, everyone's going to be receptive to it. For chronic opioid patients, there's a couple of those clinical pharmacists that we try to call them every 6 months just to see how things are going, especially if prescriptions are escalating, and talk about ways to help with their pain. Otherwise, the other, besides just education, was the workflow. So sometimes, ideally, if a patient drops off the prescription, we give them the screening, fill it out while we fill the prescription, and then the pharmacist will talk to them when they have the prescription at the end. So that doesn't always happen. Forgotten until the person, the patient drops off or consumes. And so a big thing that we're seeing is the patient waits for these opioids and then the screening already waited. They don't necessarily want to wait for fill out that screening form, and then if you want to recommend Narcan. So one way we try to work on that is from the pharmacist checking or even checking the prescription, having someone run the screening form to the patient, and so then they're done about the same thing. And then we as pharmacists will try to preemptively if we think that's something that they would really benefit from, and then that way if they can find it, just reverse it.
Those really good tips. We'll I think we'll probably start back at you, Nathan, and then just go back down the line, because I think this is something that is really important for every topic that we have here. And so that the question about, are there any additional resources or support that you would have wished you would have had to facilitate a smoother implementation for you or others? So now, you've all done this once, right? You've all started this process. And so if you were to go back, what are some things that you wish you would have had, or you would maybe do differently? And then that's really good feedback for a lot of us in the audience too, who have helped you to facilitate some of these things. So.
Yeah, I mean, like I said already, I thought our application was pretty simply. We were well trained, the CAP Center training we went through. We also had quite a lot of support with some site visits and help with this tobacco cessation. I would encourage anybody who doesn't have a tobacco cessation program going. It's not too bad to set it up. It doesn't take a lot of extra resources. You can involve technicians in some of the initial screening questionnaires and things like that. Pharmacists obviously probably need to do consultations, but we try to schedule those so that I do it on days when we have two pharmacists there. That helps us work it into our workflow. But we do accept walk-ins too, and I'm not going to turn anyone away if they happen to come in and want some help with putting tobacco. We figure out a way to do it. We do put the billing parts of it aside for a later period when we're so that doesn't take that time during this day. Extra support, I can't think of too much other than I have to mention our public health in Sargent County and Lancet County especially. They do have some grant funding available through, I believe, tobacco settlement monies and things like that. And they've been very good allies for us. We work very closely with our public health. They've always done some tobacco cessation work, and they're very pleased that we now as pharmacists can get involved and actually prescribe these products, the nicotine replacement products, the prescription products for tobacco cessation, because they didn't have that ability in the past. They had to refer people either to Andy Quits, which is another good source for support. But it really is a nice working relationship, and we use them for certain patients, like say I had been a VA patient who doesn't have any other insurance other than veterans benefits. They didn't have a way to get their nicotine replacement paid for through my pharmacy. And I could refer him to our local public health, who has the grant funds available to supply some of that. And we actually supplied the nicotine replacement. But public health has arrangement with us so that we can send a bill to them. They'll take it out of those funds, those grant funds, and reimburse us for them. So it's a nice collaboration. We refer patients back and forth. They refer patients to us that need prescription treatment. We refer patients to them if they don't have insurance coverage. So I encourage you to work with public health, not only the public health people already have this, but it's a good relationship for us.
It's great to hear. Hannah, do you want to talk a little bit about that same question about, if you had to do it differently or any other resources or tips you would have if you had to go back and?
Yeah, so you document your one screens on DocStation. And we work with DocStation. It's integrated with our pioneer system. And so every patients who picked up opioids still put in their name and patient directions, doctor, and all that stuff. And so it usually have a few weekend tasks. The technician will put them in at the end of the week. And so our doc stations put in all that information. So I'd say that was for some of their implementation, I would just do that. And we also work with our health department, so we work with public health and district health department. And they give us free Narcan, so that way we can prescribe Narcan for free. We would like to put it through their insurance to see if we get any kind of reimbursement, but with workers' comp and a lot of other insurances, no one's going to apply if it costs money. So then we can at least get the option. But Medicaid will cover, forget it's like 6 months or something like that.
I think the main thing would have been either having a better segregation of our different inventories, or like a separate fridge or a dedicated shelf for it, because we had a whole box of immunizations that were given out as private supplies. So then we had to go and do a bunch of transfers and stuff like that. We don't have any Medicare B, so a lot of people that do like the test strips and stuff that are used to separating their inventory, it'd probably be easier for them. But we didn't have anything like that, so people weren't, it was in a big red bin with like VFC stickers all over it, but still, it was a challenge for us.
And so just to reiterate for those that are a little unfamiliar with the VFC program, when you become a VFC provider in pharmacy, you get the vaccine at no cost. Someone's paying for it, obviously the government's paying for it, but the pharmacy does not have to pay for the vaccine. But because of that, since that vaccine is technically free, you have to keep it in a separate stock area, correct? You can't be pulling that out and giving that to patients. That's a separate stock, so.
But implementing ours, we luckily have a tech or a couple of tech at each store that is very well versed in Medicare billing. And then, so there it was transition with adding on, because they don't want to put for and all that stuff. But with other programs like Medicaid, when billing that, we found when they're going to the prior auth portion, to try to bill the sensors first, because that's what they recommend on their own PA forms, is to do the sensors first, and they process quicker for getting any receiver transmit, if the G6, the Dex from G6, for getting approved. If you do it out of order, then you need to get it. So maybe just getting in the habit of billing those sensors first, even if you're not billing Medicaid. And then with commercial insurance, a little bit more straightforward than the other two federal programs. A lot of times, if they're type 2 diabetics, they want to make sure they're on insulin. So just kind of making sure of those points When you do get these scripts in, if it's not covered or if it needs a prior checking to make sure that the patient is on insulin, that is a chance of being covered. And just keeping the patient in the loop, letting them know I'm waiting on. It's usually take 2 to 5 business days. If it's not covered, this is what the cash price would be. Continue using your test strips as until we exchange this portion. So really just communication from the top. And having your staff being well versed in billing both Medicare and Medicaid is also a good step. And that's what made our transition fairly smooth.
For us, for additional resources and support that would have helped facilitate a smoother implementation. Medication management would have been the standardization of the service for the national level. That includes documentation standards. Pharmacy, is a little bit behind compared to medical, and just the standardized documentation of the progress note. And that we definitely had our learnings along the way there. So just the data endpoints that we're trying to accomplish. There isn't a ton of pharmacy measures today. And so adding more discrete data endpoints that were universal at the national level of what we're trying to do. And certainly for community pharmacy, the need or interoperability to have that you need to appropriately assess the patient in this service. And kind of what that standardization looks like. There's been a lot of progress made, and we've had a lot of learnings and success in all of these areas. And we feel, comfortable at this point, but it would have been a lot easier if some of those things were in place when we first started. So really proud of how far we've come and to share our learnings with others to start implementing the service.
I would just want to answer this. I'm sorry the platform that's available to everybody. But maybe just letting our staff forward where to start. We did just pharmacists. I think we started off with using technician students and pharmacists, getting everyone all on board right away. That was getting a little smoother, but at that point, Jamie's down here.
Yeah. Jamie just joined us here to teach. Jamie, if you want to just talk a little bit, kind of give a quick introduction of yours, innovation, then we're going into, or just, what you're presenting here at the panel. And then also, we're just talking about what other resources or, lessons learned or things like that, that we wish we would have had before we started the new service or innovation.
Hello, apologies for my tardiness. My name is Jamie Stagg. I'm faculty at the School of Pharmacy. I'm a scientist in the CAP Center, and I'm fortunate to be able to have a practice site at School of Pharmacy, where my goal is to help the farm implement clinical types of services in the community pharmacy setting. With that, focusing on vulnerable populations. Right now is Medicaid and medical billing options available to us. With implementation, I'll kind of keep it more general in that you need to take a methodical approach. You need to use your implementation science techniques. At the same time, you also have to realize that if you wait for something to be perfect, you're never going to do anything. So when you launch, you need to know it's not going to be perfect. You need to bring that continuous quality improvement approach to this. And a key part of that is communication. So when you launch something, you seek feedback. You communicate with your staff, you get the feedback, and you make adjustments. And then you get feedback on those adjustments. And you continue that process as you work your way to getting things closer to that perfect state. One of the things I wish that maybe we could utilize more or should have looked at closer is just making sure that we're aware and utilizing all of the resources that are available to us. looking at the Medicaid services that we provide. Their pharmacy medical billing manual, I know it's a long and detailed, that can maybe look a little overwhelming if you're first starting down that path. But it's great, and that it is detailed. It can give you some guidelines on what you can do and helps guide you through that process. The one other thing I would add is just the utilizing the data that's available to you. One of the things that we've tried to do more now is that instead of just saying, here, we're doing this, we're utilizing our pharmacy claims data to identify people that could most benefit from the service. So those that have the most need. And then Brittany is my student right now, she's making many phone calls to those people. Trying to engage them and get them to take part in the services.
Great. So now we're gonna kind of look into just the added value of the service. We can start, Jamie, you can start us off and we can kind of move the microphone back all the way down to Nathan, but not only value of the service to, profitability or measure of success, but also I'm gonna kind of combine two questions, even also like patient stories, is there any, patient impact? I know that, Madison already shared one with us of that, patient impact, but is there, value seen not only in profit, but also for patient impact and success? So Jamie, you want to start us off or?
Sure. Value is that we're focusing our efforts on reimbursable services. So that's part of it, is that we are trying to, between outcomes, Medicaid, MTM, and different things, we are focusing our efforts on services that provide reimbursements. In addition, there is the additional value that these things bring to the patient. A couple of examples I can give is we're doing some VSC work as well now, and some of the people that we've engaged, they're not ready yet to have their child immunized in pharmacy yet. We're working on that there, but what's happened is the education that we provided, followed up and checked the IIS a few weeks after we talked to these people, and they're going to their pediatrician and getting that vaccination that we spoke to them about. So that might not have happened, wasn't for that interaction that we had. So that's a win. Another example I'll give is we have comprehensive medication review patient that has identified issues that we're working with that person to resolve. And she found so much benefit from that conversation with our student that she got her daughter now we're working on getting authorizations in place and everything for her to come in and receive that service as well. So we're seeing referrals come to us based on the care that we're providing.
I'll just add to that a little bit. It's more, just to slow down. So we're doing sometimes 500 prescriptions a day, but slowing down and taking that time to addiction. And that's kind of what we all want to do, is have that patient-to-patient interaction, and know who they are rather than just having a prescription number. So we're going to slowing down and having those conversations that you already want to have or should have. And it's just kind of taking that mental note of again, taking the time to get to know the patient.
Mm-hmm.
We've been evaluating value from CMM services, looking at objective information, certain population health data, measures or case measures or CMR completion rates, also services or from a profitability standpoint, other population health measurements, looking at costs, avoidance or reduction in the overall health system, Also looking at our collaboration efforts and trying to measure that objectively. So looking at provider response rates to the recommendations. And then most importantly, our patient experience and the impact that they've had on their health outcomes. So one of my favorite examples that I often share as a demonstration project, but for, we're talking with other partners or health plans service. We had a complex patient for chronic diseases, diabetes, hypertension, chronic kidney disease, depression, anxiety, and insomnia. She was on 19 medications, and after a CMM visit with one of our, there were 14 medication therapy problems that all pretty significant contraindications with the chronic kidney disease, amongst other things. And at the 2-week follow-up mark, the provider that we were working with had accepted 8 recommendations and a significant change to the patient's medication regimen. And so I think that's just a great demonstration of the complexity of patients that the community pharmacists have an impact on. And also collaboration efforts that it takes to, see the value from the service.
So I kind of gave one example of the benefit, but we do have multiple patients using CGM currently. But from my previous example of Medicare reimbursement for this patient, before even the portion that is captured comes back, that portion, I call it the copay, but what basically comes back is either Medicare will say, yes, we'll pay this portion, yes, we'll pay some of it, but not what you're asking for, or they'll say, yes, we'll pay some of it. So before we get any of that back, we're up $40 for sensors, about $25 for the receiver, and that's not including patient training. And portion that is still left over will be up over $200 on the sensors and $123 on the receiver. And that's pre-rebate prices on that too. So it can be profitable. I don't know how much of that captured portion we truly do get. And also I don't know what portion of that is going to be patient responsibility, especially because it was towards the middle of the year. So I don't think she had met her deductible yet. There might have been some patient liability on that. Reimbursement was a little bit less with Medicaid. It's a little bit closer, which is kind of hitting even, so you kind of rely on the rebates with that. And then commercial insurance is really dependent. I would recommend keeping an eye on your commercial insurance reimbursements. If they are ever negative, highly recommend doing an appeal. I believe it's the max level cost. And those do change when people do advocate for themselves and for similar pharmacies. So if something doesn't appeal, it doesn't just your own pharmacy, but is approved, it benefits all pharmacies in your similar situation. So don't be afraid to do those, search those out, because this can make a difference. Keeping you from providing these services.
We've done much marketing and people don't really know that we do the VSC program or VFA program, both of them. So I would say it's been extremely profitable. It's been saving us from having losses that we might have had. The value has been more of offering additional services to our patients, having a more robust immunization service, and just being able to help a population that we couldn't help before.
So success, I mean, like I said, reimbursement, especially, you're gonna counsel the patient on their rate. So it's nice for the reimbursement for that. Just, I've had so many meaningful conversations with patients who also relaxes or mental illness react with their, interact with their opioids. And then just giving back. I think some people get really frustrated or, they think that when I recommend that's definitely not what we want the patient. I always mention. You guys like my house? And actually, I did read that CDC's data drug overdose reporting system, that 64% of people who died of overdose in 2023 had at least one potential infection, such as a potential bystander. So just giving our can to anyone that will take it, especially prescriptions, and just seatbelt, wear your seatbelt every single time. But that's kind of how we relay that with. And then I guess with the success story, multiple times. I work at, we've had someone run, we work in a patient grocery store, and we had some at the grocery store or from the parking lot yelling that they need Narcan, and so we've been able to provide that to them. And another, I guess another way to help people with Narcan is that I like to emphasize, you aren't sure if that person needs Narcan, you can still give it to them, and if it's needed, it's not gonna hurt them. And so I think that takes off for sure people if they're.
I guess on the participation, it's kind of obvious that we have had some good success stories, patients that people have been able to quit, and obviously improve their health in that way. We have had a number of failures as well, people that drop out of the program or just don't do well, maybe treatment program that we thought would work well doesn't work for them. But I don't look at it as a failure, I look at it as just another step in their process, and hopefully eventually they will grow. I had mentioned earlier about the winter Bobcat manufacturing plant. It's just 8 miles away from Foreman. And they kind of, I thought a good success story was that I was able to get in with their, they have a non-staff nurse at the facility. And I had a very good conversation with her. She was very excited about the work that we were doing and thought that it would greatly benefit their employees that they used to have. She has been an advocate for us, giving us referrals, helping us pass out brochures, get that information out. And we've had even, that plant has 3 shifts, and one of them is the 11 to 7 overnight shift. That doesn't exactly fit into our pharmacy's hours, but we have had some success, even though the patient maybe left work at 7, got home. We've done some audio only telephone type consultations with some of those overnight shift people, and been able to help them in that way. Even though they weren't in person in our store during business hours, we kind of work with them best we can and to help them. So that's one success story. The other thing that this whole process has done, and I kind of thank the CAP Center and some of their assistance with the medical billing side of it. That was kind of a new thing, other than billing some GME and stuff like that once in a while to cross. We hadn't done much medical billing. And that's different from pharmacy billing. Pharmacy billing was through your pharmacy software. It happens quickly, and basically accept whatever they give you. Medical billing is a lot different. I mean, it takes a different way to bill. It's some different computer platforms. I've even done paper forms and faxed them into, say, Next Blue. I have trouble billing them, but if I fax them a CMS claim form, they will pay it. So, we've been kind of, we don't give up easily. We figure out how to get paid. And that expertise now in medical billing, I'm seeing a lot more opportunities. I don't know if it's a secret, but did you know that when you do an immunization, you can build your pharmacy software, you get the $15 and $20 registration, whatever they might pay, a little bit over cost on the drug. That means can also, now that we have pharmacists that are credentialed, you can bill those as a medical vaccination. And apparently they pay doctors and nurses a lot more for vaccination pharmacy. Because we can get $30 more for the same vaccination if we bill it as a medical. That was new to me. I just learned that about 3 weeks ago. So we're kind of dabbling in that. I'm pleasantly surprised it's not much more difficult. So a lot of times we just skip the pharmacy PPM contract. We bill it as a medical service. And because our pharmacists are credentialed, we're the prescribers for the vaccination, and it sails through very well. So I'm happy about that. We've also made a little bit of adjustment this summer. We adjusted our rates for our tobacco cessation work because we realized what we had initially set way back when we first started the program was quite a bit below what Blue Cross was allowing on their medical fee schedules. And those fee schedules are open. You can pull those up online also. You can see what the maximum was. We raised our rates for tobacco cessation from $25 to $30, and now we're getting full reimbursement across all. Before that, we were just waiting for the table for $100. So we need to value our services for what they're worth. Yeah. We really haven't had co-pays for tobacco cessation. Most of the insurances do cover the product 100%. Now, one exception is the Sanford Public Employees Plan. We just did one this week, and there was co-pays on tobacco cessation products. So again, we worked with our public health, and they agreed to pay the co-pays for us for that patient, which is very nice. He was a young kid, 19 years old, hooked on vaping, and we appreciate that. Otherwise, the co-pays, I don't charge, I guess, a co-pay for the consultations. I don't make them pay anything up front. I guess if it was something that wasn't covered or I couldn't get a bill, I would write it. No. Yeah, I'm just sure what the time. I guess probably within a couple weeks. So I haven't run into time limits, but I think some insurances do have a limit, maybe 6 months or a year. Yeah, I haven't run into that either. Although Blue Cross on tobacco products, cessation products, I think they do have a 6-month window, and then they won't cover it. So sometimes we run into that, and again, our collaboration with public health and things get around it. But I haven't seen any limits on the actual consultations and follow-up visits. We dedicate for all those. No, we're credentialed, and we are building across North Dakota commercial, North Dakota Medicaid, North Dakota Medicaid expansion, kind of goes across Sanford Insurance. We recently got credentialed with Next Blue, which is an Advantage Plan program through Cross. And I'm working on United Healthcare. All of that is a little longer process. I haven't gotten to that. But we know we are recognized as providers through federal Medicare. So those people that have traditional Medicare with a drug plan, we aren't able to bill that as providers. But the Advantage plans have a little bit different rules, and they can credential us as far as I know. They will stop them.
But just to kind of as a good little pause here, you know, if you're not already credentialed to be a Medicaid provider, this is really the time and call to do it. So, you know, everything from the CHW work that's coming down to the VFC for, and the billing for the tobacco and all that, that is so much centered on getting credentialed as a provider through Medicaid. And so if you haven't done that, or your pharmacies still don't have pharmacists that have done that, just putting out a call that this is the time to do it. We have some great guides on the CAP Center resource page, as well as Jamie has kind of already, you know, South Point's gone through the process and has put together a really great guide, and we're here to help you with that if you have challenges or questions, but it really is a really great time to do that. So I think what we'll do here is we'll take a few questions from just at this time, and the audience will probably take a quick break, and then we'll come back and finish up with some other discussion. But are there other questions? I know Katie kind of broke the ice a little bit, but are there questions from the audience? Yes, Gail, and I'll repeat your question if that's okay up here. So.
Monitors not being continuous data. Have anybody on the Libra 3 yet? I know that one said continuous.
Yes, so that is the benefit of Libra 3. I do not on Libra 3 yet.
but that is an advancement looking for original. And Libra 2, you need to hold the receiver close, but Libra 3, which is freestyle out, has continuous data sending to the receiver. So both Dexcom 6 and 7 do that.
Libra 3 will go through the phone now, so. My 9-year-old father-in-law can do it, so.
Yeah, the receivers are great. Basically, just like a little phone. Just kind of patient preference on if they want to use it. Sometimes it's good to leave it. I know when certain clinics were willing to give the Dexcom 7s to replace the full Dexcom 6, they needed to see a receiver built or get a receiver turned in before the Dexcom 6 before they would send out Dexcom 7. So there's something to keep in mind. It's not mandatory for patients to have a receiver built or to get a receiver. But just know that there's some instances where it is beneficial for a receiver to be built even if the patient doesn't really use it.
So just to add on, I struggle with low blood sugars when I'm pregnant, so I'm able to work with your Dexcom personally. And there's now an OTC option for Dexcom. And it's all through Dexcom's website. It's exactly like Dexcom, but it's just and it lasts 15 days. So if you sign up for a like continuing every month, I think it's $90 a month and then $100 a month. But personally, Dexcom way better than the first time. We were great. It was like in the 60s. And the alarms go off and they don't stop. But with Dexcom, it's been much more accurate, I would say, and then more user friendly.
Questions, and a panelist can ask each other questions too, so don't feel like just because you're a panelist, you can't, ask other questions. Any other, yeah. I'm glad, no, this is forward, they can go ahead.
Maybe somebody could talk about and also just when you talk about this time for, when I go around to different pharmacies with my inspections, they're like, well, we still not have time for this. So how have you made, what have you done to free up some pharmacist time?
I would say now that we're in flu season, the biggest thing we've done is have all of our technicians become immunized. And that has taken a lot of time for us pharmacists to focus more on clinical work. I would say the biggest thing is like utilizing things that techs and students can do and putting the focus more back on their clinical work.
And to add into that too, and you can pass it down to Sam too, but just to add into that even, with what Jesse had mentioned earlier with the CPA, the test with 3 options with like strep and influenza and all those, the pharmacy technicians in North Dakota changed the rules, and now pharmacy technicians can collect. And that drastically reduces the pharmacy time. So the pharmacy technician can be doing the strep, the influenza test, they can be doing the blood glucose test. They can be doing those tests. They can be the one actually performing the test. Again, and then allowing the pharmacist that time to triple the tests and having them on call with the patient. So another thing that, as you're implementing these, looking at ways to expand the scope of your pharmacy technician.
I was just going to add and echo what Jessica said as well, and just the pharmacist scope continues to expand. So we also continue to really leverage our technicians to the top of their practice. Mentioning immunizations, but also technician product verification in our component here, and then also being able to fragment parts of service, whether it be the initial patient engagement around the service to help with the setup and getting the schedule, the patient in the door. They have great relationships with patients. I think, tying back to the community health workers and technicians being a good person from that relationship piece is very valuable. And then I also think, diversifying our services that we talked a lot about today to, be economically sustainable in the landscape is also, important to leverage technology enhancements too, to support this, traditional dispensing in your pharmacy as well. So whether it be advancements in your, pharmacy management system or how you fill prescriptions, and I think that's an important part of it as well.
Just kind of a reiteration, North Dakota probably has some of the best trained and best technicians in probably the entire country. As to that, I have worked in states, and by far the North Dakota technicians are most versatile, and very knowledgeable. Because in my introductory example, I didn't really have much contact with the patient or the doctor until patient came in patient training. So it was the technician that reached out to the doctor, sent faxes, listened to the patient and all that stuff. So it really is, technicians are the backbone of the pharmacy and allow pharmacists to be as limitless as we have been able to continue efficiently use these services.
What maybe as far as the CM control stuff, I'm kind of getting prepared for January, when the legislative rules kick in and say that we are able to provide these insurances applications. Is Thrifty White doing that for central location or each store? And then are you billing for them yet? Or are you just getting ready to go, hopefully, January? And I know the committees are still working on the details, but we hope to be able to do that.
Yeah, so we are billing the service in Minnesota. And how we started the service was it was rolled up to all of our pharmacies, but kind of in our process of using the platform and so we did take the service centrally while we worked on additional training and for application platform and systems to align expansive service and ensure that we had continued quality for the health plans and expectations. And then, then rolled the service back into our pharmacies because of the importance of the local pharmacy relationship. And in terms of implementing that in workflow, that was a very big part of it. It's more comprehensive and not just be one type of intervention, or education session, and so allowing the pharmacist to do a more comprehensive visit was really important, and so that's kind of leveraging our technicians, our workflow, and having an efficient way to document. Not in North Dakota.
One clarify for you. When you say you're billing for medication management, you're billing medication management billing.
Yes, that is correct.
Any E&M code or CDM code or whatever.
Right, we are billing NTM codes in Minnesota, however, the health plans define the service as CMS. So we are billing NTM codes 96567, but it is CMM as the service.
I just wanted to add one more thing to Gail's question about integrating into a business pharmacy and that workflow-wise is that we tried to do things at South Point too that allow us to a couple of things. One is I always like to say like a bundle. If you're doing a CMR, also check the organizations and things like that. So it's bundle things together as much as you can at once. But the other thing that we've done too is we've tried to put notes in our pharmacy system for people that have tips or CMRs or are eligible for different services, so that we then flag their prescriptions, so that when they come in to pick up their prescription, we can then have that conversation at the counter as our board inspector likes to always remind us for the counselor when it comes in. So if we're able to, while we're doing that counseling, also take care of a tip or sign up to come in for a comprehensive medication management session. You know, those are our opportunity to engage them, get them to participate is much higher face to face rather than, you know, trying things over the phone or other types of things. Yes. That is a little bit different, and then we do schedule those when we have some dedicated pharmacists or student time to be able to do that. We have, Jeff is great in that he's given us certain windows where we are able to dedicate more staff time during what would maybe otherwise be a traditional slower times. So that we're making the most use of that downtime during this. The question was how we handle medication therapy management for Medicaid, because the initial visit with Medicaid is required to be face to face, and then follow-ups can occur via telehealth, but that requires the video component, not just the telephone, to my understanding. So we for the most part are doing the face to face visits. It's taking work. It's not the easiest population to engage, but we're learning lessons. We're fortunate that we have APP students as well on a fairly consistent basis, that they're doing a great job with outreach and helping us identify the right approaches. You know, you tell someone your insurance wants us to do this, you know, it's a lot easier, but you know, it's more, we need to make sure our records are, sure your medications are working for you. All we use is consultation, taking that type of approach, making an opt-out versus an opt-in, you know, those are all those different types of approaches that help. We're going to have success.
Yes, Cassie.
I just have a comment from Turkey White. Just from our experience in, here landscape with CMM on the Minnesota side, kind of the major player all had different expectations. It made it very hard, especially when we send a lot of external audits. So typically the turnaround time is 48 hours to supply what they're asking for. And so that added to a lot of our documentation changes, but I mentioned that because I know some of those layers are in North Dakota, and so when we transitioned out of the almost platform into CML, that's where those documentation standard is different. And then we had ongoing make adjustments to our process. I just mentioned that knowing that we have a lot of experience and from an administrative perspective, there the audits can be, you know, overwhelming with the number of cases that you're doing.
I hope that the CAP Center, maybe as it starts rolling out across the state, maybe the CAP Center could help us with some documentation standards, information like that, what it would look like, so that we don't all have to mention that alone.
Yeah. Brody, do you have anything to mention about that as to, do you know, I mean, because you're on the task force, are you not, the legislative task force? I don't know if you have any comments, because from what I understand, that has not been set yet. There's certain things that have been, am I right? There's certain things that are required for the payers to, there's like stipulations, but what that actually will look like has not been defined, correct? Yeah.
Despite having a legally mandated committee to develop the implementation of CLM come January 1st, you know exactly what it is. Our peers have not dictated what CLM would look like, all the documents, so it's not this. I don't know. Sorry.
That's right. And so, yeah, so I guess TBD. And I think what we'll do now is a kind of a good, oh, Sam, were you going to say something? Okay, we'll take just a few minute break here. I know it's almost the end of the day, but if you need, I think we have a sugary drink over there. And if you need a little extra brain fuel or a little coffee, but
take a few minutes, and then what we're gonna just do right before we close out is kind of have you just come back to the tables and then just identify potentially, like something here that maybe you're gonna walk away with today, like something you might want to try, or maybe it's something that you want to learn more about, or just like a step that you might want to take. And then also we're gonna have you identify what would you need, right? Because like that's really what the CAP Center is here for, and we're collaborators. And so, if you were to do this, what is it that you would need? And then we'll also just have time for Q&A too. If anyone has any other questions, our panelists are here and you can ask them too. Just take about, is that okay, Lisa, 5 to 10 minutes? Yeah, let's just do a quick 5, 10 minute. We'll come back with our closing and make sure everyone gets that. Okay. Thank you guys so much for agreeing to do this. It's go. So just a couple, closing out today. Um, so, um, you know, shame on us for being, for doing this like CPA and what that means and for everyone, and I know we even have some students that are joining us today. So just as an example of what, you know, the CPAs are in North Dakota. So those are cooperative practice agreements, and so what it means is you can actually prescribe medication under what the pharmacy service for, that they contract with. I really to sign on as being a prescriber of record. So example being, I think the strep protocol is 5. And so if you are a pharmacy and a patient comes in, child that's 5 years old and they think they fall, you know, symptoms of Lyme strep, you can provide a CLIA waiver test, which is allowed by a board of pharmacy. And then if they get a positive, they don't have to go to another provider or physician, you can actually prescribe them the antibiotic. Same thing with influenza. I think there's one for albuterol if you know, for that, if you have a history of needing a, you know, a rescue inhaler. Same thing with a patient who might need birth control for easy access. So what happens is that the pharmacist provides the services usually cash. I mean, there is billing opportunities, I'll just say right now, it's primarily usually cash based. Then the pharmacist will charge the patient for that and then provide that medication. So it's kind of what that is and what those CPAs allow for that number of services that you have shared. And I also want to point out that for all the attendees, we're going to be sending out the PowerPoint slides too. So you'll actually have a site as well as contact information for Jake, us, and the other speakers too, if there's any questions you have. So kind of just thinking to, you know, if there's any kind of the last minute closing remarks, but from what you heard today and the different opportunities and things that, as well as our currently, any questions that anyone has, or maybe additional resources that you think would be valuable to expand upon any of these services that were discussed today? Yeah, like it was Tony, I knew you'd there, but it was hoping you would. Good icebreaking.
Doesn't know where to start, get something going, or needs help with it. Is that something that counts?
Yes.
Pharmacy.
Yep, so for some of these services, we actually have funding to do like on-site services, and so on-site consult. So if you are a pharmacy that wants, for instance, like work with something with immunization or do more with like, or want to become a VFC provider, we will send someone out to your pharmacy. If you want to start providing pediatric vaccines, not really quite comfortable with it, we'll send someone out. And so I think the question is always ask, you know, so even if we don't have the resource right there, for one, we don't have resources, you're telling us that we need to get that resource. And that allows us to advocate or get that resource. The second is that more than likely have that as a resource available. So by all means, contact the CAP Center, as well as, you know, and we will direct you as to where to go if we don't have the right answer. More than likely, the answer would be yes. So we can do that for you. Other questions or from today or thoughts?
So it's been a long day. Well, with that, she comes back in, then I'll shoot. But with that said too, you know, a lot of opportunities coming, be looking for communication from us on the work of community health workers and pharmacy technicians, and as that moves forward, as well as CMS, we're getting more information on that. Oh, shall we all sing happy birthday to you? Happy birthday to you. Happy birthday, dear Tiffany. Happy birthday to you. Thanks, that was perfect to walk in. So thank you for being here on your birthday with us. So, but with that said too, you know, as things come out and we're going to be doing our best to keep you informed of other opportunities. I know you get emails, try to look for those emails. And also have other ideas. By all means, if you think of something that you'd like to heard other pharmacies doing or you'd like to get started with, I would love to hear about that too. That gives us other opportunities. And we have some other things that are in the pipeline as well. That are other opportunities that will be coming to our business. And so, too. And then, yeah, thank you to all the panelists too. Thank you. Well, I've got thank you. All right, so with that said, keep up to date on the next symposium. Always are, and if you ever have any ideas for next year's symposium, we're always excited to hear those as well. So thank you for taking time. Is that all, Lisa? We're good? Okay, thanks everybody.